Welcome to the first part of our Shared Maternity Care Collaborative Workshop. The second part will be next week. This evening we'll be talking about third trimester issues and perinatal infections. And this shared maternity care, I'd like to acknowledge that with regards to on behalf of the Royal Women's Hospital, Mercy Health, Northern Health, Western Health and Northwestern Melbourne Primary Health Network, acknowledging that we're meeting on the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wotherong people. That's from where I stand this evening. And we pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in this session with us this evening. Just some housekeeping. So all attendees are muted. Please ask questions via the Q&A box. And at the end of each presentation, I'll just ask questions based on a thematic analysis of those blocks. So after Stefan's session and after Lisa's session. Questions will be asked anonymously to protect your privacy. Please ensure you join the session using the same name as your event registration or the phone number if you've dialed in. Northwest Melbourne uses the Zoom's participants to mark attendance and certificates and provide CPD attendance. If you're not sure if your name matches, please send a chat message, but only to the education, to Northwest Melbourne PHN Education, to identify yourself in the chat box. This shared maternity care collaborative is brought to you by the 4 collaborative hospitals. So Mercy Health, and the 2 people that run the primary care liaison service at Mercy Health are Caitlin Shaw and Sharon Tijan. Northern Health, the 2 people that run the GP liaison at Northern Health are Dr. Richard Sear and Dr. Arzu Khalid. Western Health, the 2 people that run the service at Western Health are Sky Spencer and Dr. Joe Silver, and on behalf of the Royal Women's Hospital, Emily Lawson and myself. Many of you know me. I run the general practice unit at the Royal Women's Hospital. I also have the privilege of being one of the GPs in outpatients in Yellow Team, and I also provide the clinical advice and support to the shared maternity care unit. In addition, I'm a GP and on several government committees. So this session will be talking about third trimester issues and perinatal infections, and I'll also give some hospital updates at the end of that. So starting off with Stefan, Associate Professor Stefan Kane is a maternal fetal medicine subspecialist obstetrician who has the privilege of serving as the Medical Director of Maternity Services and the Acting Director of Maternal Fetal Medicine at the Royal Women's Hospital, and we're all delighted to have him in that position. His clinical engagements cover the full scope of complexity in pregnancy care, from multiple gestations to complex fetal anomalies and significant pre-existing maternal medical conditions. Stefan holds an honorary appointment as a clinical associate professor at the University of Melbourne, Department of Obstetrics, Gynecology and Newborn Health. So thank you, Stefan, and over to you.
Well, thank you very much, Inez, for that kind introduction, and thank you for the privilege of asking me to speak tonight. I'll just share my screen. Assuming you can all see that. So yes, I do have the privilege of serving as the Director of Maternity here at the Women's, and I've been in this role now for coming up to 2 years, but have been at the Women's for much longer than that. In fact, I started here as a resident and have really never left, which I think says something about the institution. And over that time, I've had the privilege of working with Inez for many years as well. So it's a pleasure to be here. And I'll be discussing third trimester issues. Now, that's obviously a huge topic, and I've tried to condense it in a way that is hopefully relevant to the audience here tonight. So I have received honoraria from Organon and Basins Healthcare Australia, but the content of this presentation is unrelated to those areas for which I've received honoraria, and all images used in this presentation are free from copyright and are fully available in the public domain, and I can provide references as needed. So this is what we'll be covering tonight. So non-cephalic presentation, small for gestational age, large for gestational age, decreased fetal movements, cholestasis, hypertension, and induction of labour. So as I said, quite a broad spectrum of topics. And please, well, as I said, we'll have questions at the end, but Inez may ask some questions as we go as well. So just some definitions around fetal orientation, and I mentioned this, and this will be very familiar to many of you, but it's still, I think the language we use, it's important that we're all using the same language around these concepts. So presentation is the part of the fetus, or the presenting part of the fetus, that is located closest to the internal cervical os. And this can be cord, of course, which is called a phunic presentation. And a cephalic presentation normally refers to the vertex, so that's the topmost part of the head, so the head in full flexion. But technically, a face presentation, which is when the head is hyperextended, and a brow presentation, which is midway in between, are also, I guess, forms of cephalic presentation in a way. And in contrast, the position describes the relationship of the presenting part to the pelvis, to the maternal pelvis. So you'd be familiar with occiput anterior, but if the baby's breech, then it's sacrum transverse and or transverse anterior posterior. And the other, I guess, numerator, the other fetal anatomical aspect that we describe is the chin. So for face presentations, we mention anterior, mention posterior. Whereas lie describes the relationship of the long axis of the fetus to the long axis of the uterus. And most of the time, babies are in longitudinal lie if they're breech or cephalic. So non-cephalic presentations are those where the presenting part is anything other than the fetal head. This can be the breech, an extremity, so a hand or a foot if the baby's in transverse lie. It can be the shoulder, it can be the back, or it can be the cord. Now, if it's a placenta previa, we wouldn't say that that's the presentation. There's still some part of the baby or the cord that would be coming first. It's generally not an issue until after 36 weeks. And the vast majority, 96% or so of babies will be in cephalic presentation by term, by 37 weeks. So at 36 weeks, around 4% of babies are breech, and this falls to about 3% by 40 weeks. So there's a 25% further reduction by 40 weeks gestation. So a key point here is that all women anticipating a vaginal birth should have a presentation scan at the 36-week visit. And this is certainly something we try to do at the women's, and I imagine is something that's done at the other services as well. And that's because clinical examination is notoriously unreliable. Probably won't surprise you to learn that midwives are better at it than doctors. The sensitivity in detecting non-cephalic presentation is 70%, while specificity is 95%. So if we think a baby is non-cephalic, we're generally right. But even when we think the baby's cephalic, in fact, 30% of the time we're wrong. So that's, I think, a good enough reason to do a confirmatory simple test that will let us know for sure if the baby's cephalic or not. And that's important because if we don't identify that a baby's breech, then we might deny someone the opportunity to have intervention or interventions that may prevent the baby from staying breech. And so they might, come in labour with a breech baby, whereas if we'd found it to be breech at 36 weeks, they could have had an ECV. So the management options, of course, include external cephalic version, an elective caesarean section, or expectant management, anticipating either emergency caesarean section or vaginal breech birth if version does not occur, or of course, a vaginal cephalic birth if version does occur spontaneously. And another key point is that infants who are in breech presentation in late pregnancy, so really from 32 weeks onwards, should all have screening for hip dysplasia, even if born cephalic. And I was amused to find that there is, you can buy a t-shirt highlighting the importance of awareness of hip dysplasia. Not quite sure how big the market is for that, but anyway, it's amazing what you can buy on Amazon and other online vendors. So ECV, external cephalic version, is safe and effective. It's of any sort of intervention in medicine, I guess it has one of the lowest numbers needed to treat of 2. So it works 50% of the time. There aren't too many other things that we do that have such a low NNT. Serious complications such as cord prolapse, abruption would occur in less than 0.5% of the time, and that's from Australian data. And about 3% revert back to being breech afterwards. It's optimally performed from 37 weeks onwards. You have higher success rates if performed earlier, but you have higher reversion rates too. And of course, if you do it earlier, most of these babies were going to turn by themselves anyway. So you're potentially subjecting a pregnancy to risks when nature might have sorted it out by itself. And of course, it's better to wait until 37 weeks as well, because if a complication occurs and immediate birth is indicated, that way you're closer to term rather than potentially having to deliver a baby iatrogenically at 32 weeks or so, or 34 weeks. And so these are data about how babies are born after an ECV, and this is a study from Canada showing that you can see that in the controls, so these are women whose babies weren't breached, they didn't need an ECV, they labored spontaneously. They have a higher rate of spontaneous vaginal birth. Operative vaginal births are similar between the two groups, but women who've had an ECV, even if the baby's still cephalic, still have a somewhat higher rate of cesarean section in this study, so up from to 15% from 6%. So something to counsel women that although the ECV works, that doesn't mean that they will necessarily have a vaginal birth. Now, a 6% cesarean rate, I think, is very impressive, and you can tell that these data are fairly old now. I don't think there's too many populations of this size that would have such a low cesarean section rate now, and obviously the demographic of women birthing has changed significantly over time, but the increased risk would still remain, and that's probably because for some babies there's a reason that they're breached. It may be something to do with the pelvis. Obviously, this is different in women multiparous, women who've had vaginal births before. But in primaries, there may be some other factor, which is why the baby was breached. And although you could turn the baby to be cephalic, there's still a higher chance of needing a cesarean. So if we are to do a vaginal breech birth, which I think an increasing proportion of women are very keen to explore, or at least have the option of, which is absolutely reasonable. The challenge for us, though, as clinicians, is that it is becoming something of a lost art in the epoch after the term breech trial, which was a very large trial published in the New England Journal or the Lancet, one of the two, one of the heavy hitters. In fact, it's here, I can tell you, it's the Lancet, back in 2000. And virtually overnight, practice changed, whereas previously many centres were offering vaginal breech birth and providing care in much the same way as care was provided to women with babies in cephalic presentation in labour. Whereas this trial showed an increase in perinatal mortality, and so in many centres it changed overnight, and most breaches were delivered by cesarean. Now, studies and evidence from large groups that still provide breech vaginal birth care, particularly in France, where a lot of this is done, demonstrate still very favourable outcomes. And so as a result, there are efforts being made to provide vaginal breech birth as an option in larger centres. Now, this will differ from centre to centre. It's something we're still working towards here at the Women's. Of course, if someone presents with a breech baby in spontaneous labour, we will, of course, look after them and respect their wishes. But in terms of planning, I guess, more sort of elective vaginal breaches, it's something we're still working towards, and hopefully we'll get there by next year. But it is important to remember that despite the flaws of the term breech trial, and it was, it did have a few fairly substantial issues in it, the fact remains that these births are still at higher risk of adverse perinatal outcome. And these are data from a Swedish study published this year. So this is a centre that didn't stop doing breech vaginal births, highly experienced obstetricians and midwives. And there is still an excess of neonatal mortality or serious neonatal morbidity, which I think, again, the numbers are very, very low, but the absolute risks are still low, but the relative risk is not insignificantly increased. And that is something that is important for us to share with women who are considering this. And again, that's not a reason not to offer a service, but I think it is important that we be cognizant of those risks that we just can't control, and they are different when a baby's not head first. So what about if your baby is coming other than cephalic or breech? So this generally requires a lie that is other than longitudinal, so transverse or oblique. But you can, of course, have a hand presentation with longitudinal lie, so you've got sort of the head somewhere down there, but a hand coming in front of the head. And a key point here is it's important to ask why a fetus has an atypical presentation. So breech we would not generally be too concerned about, although there can still be some of these reasons listed here that might explain why a baby's breech. But certainly if a baby's oblique or transverse, especially in the first pregnancy, but even in women who've had a few pregnancies before, it is really important to go back and think, why might this be? Is there a placenta previa that's stopping something from going down into the pelvis? Is there extra fluid? Is there a uterine anomaly? Is there a fetal anomaly, like a sacrococcygeal teratoma or something that's changing the configuration of things, or hydrocephalus? Is the baby small? Are there cord complications? Is there cord? I had a baby the other day where the baby was in oblique lie consistently, and the mother wanted a cesarean anyway, having had a vaginal birth the first time, and not having a particularly positive experience with that, so wanted a cesarean anyway, and given that it was an oblique lie, that made sense that he wasn't interested in an ECV. And at cesarean, the baby came out okay, but had cord tightly wrapped around the neck 3 times. And I think this was why. It was just too short, and it wasn't able to, it was sort of being tethered to the placenta rather than having the freedom to move down into the pelvis. So I'm relatively glad we didn't pursue a vaginal birth in that context. Fibroids, so these can certainly cause babies to present in different ways. And then multiple pregnancy, obviously the twins can, and higher order multiples can be coming any way they want. So if you are rather than cephalic or breech, the management is similar to breech. You really do need careful sonographic assessment to exclude a pathological reason for the malpresentation. And again, if there's nothing sort of really blocking the internal os, so if you don't have a head or a breech down there, there is a higher risk of cord prolapse. So admission to hospital from around 37 weeks, depending on the circumstances, may be considered. And these are more likely to have an unstable or variable lie. So, one day it's oblique, then transverse, and there might be breech instead of flipping around. And as a result of this, we would often move to an induction of labour immediately after an ECV, as the risk of reversion is higher than if the baby would breech. And these are obviously more common in grand multiply because everything is somewhat more lax, and so there's more space for things to move around. So that was a non-cephalic presentation. Moving now to small for gestational age. So this is defined as estimated fetal weight or birth weight, depending on whether we're talking about the fetus or the neonate, under the 10th centile. Now, which chart should we use? Debate rages. We don't have enough time tonight, or in fact even this week, to go through all of the issues that pertain to which chart we should be using. Ideally, we would all use the same chart. That would help. And ideally, the charts would flow sort of in a continuum from fetal life to neonatal life. But as we'd all be aware, that doesn't really happen all that well. So SGA is not the same as fetal growth restriction. And again, I recognize that this is a concept with which many of you will be familiar, but I think it is really important that we acknowledge that they are not synonymous. FGR, or as previously known as IUGR, intrauterine growth restriction, is defined as a fetus that has not reached its growth potential, which is largely determined by its genetics. And how do we know the growth potential of a fetus? Well, we don't, really. This is the problem. It's all sort of diagnosed using surrogate markers, and in itself, SGA is a proxy for fetal growth restriction. So not all SGA fetuses have fetal growth restriction, and not all FGR fetuses are SGA. So you can have a fetus on this with an estimated weight on the 30th centile, so not SGA, not less than the 10th, but would be considered growth restricted if it should be on the 70th centile according to its genetic growth potential. And that's why babies in the lower centiles still have a higher rate of adverse outcome than those in higher centiles, because some of them are going to be undiagnosed sort of fetal growth restriction. They should have been bigger than they were. Whereas a baby with an estimated weight on the 7th centile, if it's been tracking that and the parents are both sort of 7th centile parents, if that's where it was going to be, someone has to be on the 7th centile. It's a normal distribution. That baby's not FGR. It's just constitutionally small and healthy. So the challenge for us is not so much identifying those babies that are just constitutionally small. It's looking for the growth restricted babies, because these are the ones who have increased rates of adverse perinatal outcome. And we can divide FGR into early and late, with early being less than 32 weeks. It's not common. There's a strong association with preeclampsia and, I guess, more defined placental pathology, like massive perivillous fibrin deposition or placental floor infarction. These are often small SGA. The Dopplers are often abnormal. We can often identify them because, the fundus never sort of gets out of the starting box, and they go off and have an early growth scan and are detected. But the clinical consequences are significant. They're of significant risk to prematurity, high mortality and morbidity. So the challenge here is not so much the detection. The challenge here is the management and picking the right time and trying to avert the complications of prematurity. Whereas late FGR after 32 weeks is more common, not so closely associated with preeclampsia or clearly defined placental pathology. Not always SGA, many of these babies. Dopplers may or not be abnormal, harder to detect as a result, and these are associated with increased mortality and morbidity. So the challenge here is not so much identifying them not so much managing them. When we identify them, we generally sort of know what to do and pick the right time to be born. The challenge here is making sure we have a consistent approach to identifying them. And of course, FGR may be the result of maternal, fetal, placental, or genetic causes, or a combination thereof. Whereas for most babies, the underlying cause is placental in most instances, or uteroplacental insufficiency, as we would describe it. So why are we so concerned about this? Well, less than a third of FGR or even SGA fetuses are detected antenatally. The antenatal detection of FGR is a key national maternity indicator of safe and effective care. And detection and care of women with FGR is relevant to all maternity care providers. And this is why it matters. So you can see here, so these are data a little bit old now, but still relevant. So perinatal deaths in Australia. And if you look at the rate of death per 1,000 births, less than a third centile, dramatically higher than even sort of third to ninth centile. So even these slightly smaller babies have nowhere near the death rates that these very, very small babies do. And that's true for all births, and it remains true after 37 weeks. So as we would describe it as term. And these data, again, they're fairly old, but from Jason Gardosi, who's done a huge amount of work in this space, showing very nicely that if you identify growth restriction, you make a significant impact on the risk of stillbirth, whereas if you don't identify it, obviously the converse is true, and you have a much higher chance of stillbirth. So there's value in identifying these babies. Now, there's also a cost to this, because we end up delivering babies earlier, and some babies will be delivered earlier than perhaps necessary, and we'll have morbidity associated with that. But until we have more precise measures of identifying exactly when each individual baby needs to be born, this is the price we pay for minimizing mortality, which I think most would agree is very much, especially at or near term, is very much an outcome worthy of avoidance. So looking at risk factors, and it's important that we assess these at the start of the pregnancy, and this is something I think that increasingly we're looking at, the predictive value of taking a really thorough history and then maybe doing some other assessments in around the sort of the time of the nuchal scan. And Kypros Nicolaides and the Fetal Medicine Foundation group have done a lot of work at looking at the value of a really comprehensive risk assessment at that sort of late first trimester stage to really predict the risk of things like preeclampsia and growth restriction and preterm birth, and then apply therapies that may reduce those risks, but then also triage to care pathways that will provide the requisite level of care. So you'd be familiar with these risks listed here on the left, and then high risk factors here on the right. So if you've had a small baby before, like most things in medicine, if you've had it before, you're at risk of having it again. If you've certainly had a previous stillbirth with a small baby, that's very concerning. And then certain maternal medical conditions are very closely associated with growth restriction. And clinically, how do we detect this? So the evidence that everyone should have a sort of serial scans is not all that robust. And so, for that reason, I think, in the broad clinical population, we would generally perform some physiofrontal height assessments. And this, of course, is the distance measured in centimeters on the longitudinal axis of the abdomen from the top of the fundus to the top of the symphysis pubis. Has these advantages as listed there, but it is clearly subject to clinician bias, intra-observer errors, confirmation bias, and variable detection rates of FGR as a result. But using a standardized technique can help, and there is evidence to show that this makes a difference. Various hospitals have certainly shown an increase in the detection rate for FGR by doing this. Not much point doing it before 24 weeks. Having an empty bladder is helpful. And then starting at the fundus, turning the tape measure the other way so you can't see the numbers, and then measuring it all the way down to the pubic symphysis, and then measuring once only, so you don't sort of, just keep measuring until you get the number you like, which is tempting, but not probably very helpful in terms of identifying the small baby. So palpation alone should not be used for the assessment of fetal size and or growth. Clearly, we need to be very respectful of those who have extensive experience, and I'm sure there are those out there who can just lay on the hands and get a good sense of where things are at. But in the systems in which we work, we need to be consistent, and so I think it is important that we take that consistent approach to symphysiofrontal height measurement. Ultrasound assessment of fetal growth should be undertaken if we think the symphysiofungal height is less than the 10th centile, and there are charts out there on which you can plot these, if growth is static or if growth slows. And of course, women with a high BMI or those who have large uterine fibroids are unsuitable for the symphysiofungal height assessment, and ultrasound should be considered.
Stefan, I was going to ask you, mentioned the fact that it's actually about identification of fetal growth restriction that's the issue. And you mentioned the fact that serial ultrasounds aren't particularly sensitive, and yet many of us, both obstetricians and GPs, are moving towards doing a fairly routine, third trimester scan, perhaps, between 32 and 36 weeks, particularly in primary gravida women. Could you comment on the utility of that?
Yeah. So I think it's a space where evidence is evolving, and in describing that the evidence for it for everyone, it's a general population where perhaps the evidence is still evolving. I think if we were to do a routine scan, doing it later, I think the evidence would suggest that doing it later would be more helpful. Like a 32-week scan, finding a baby that's well grown at 32 weeks. I guess there's a number of reasons why you might do a scan. Then one is to have another look at anatomy, and certainly that's what is done in France, looking for the later development of significant anomalies. But in terms of growth, most of the growth issues, unless you suspect it clinically earlier on, or someone's at particularly high risk when you should be doing scans anyway, most of the growth issues are going to be later. So doing a scan later on, at say 36 weeks or so, will help you identify perhaps some of those babies who might be smaller that you otherwise would have missed. But I think the evidence for everyone getting certainly serial scans is not particularly strong at this stage. And I think even a routine 36-week scan, I think there's no harm in doing it. And certainly there's an evolving body of evidence to show benefit. But again, the problem, I guess, with only doing one is that then you have a static point in time. You don't get to see the velocity. And so that's where I think it's not unreasonable to do, but it just needs to be filled out. And as I'll come to later, even a reassuring scan at 36 weeks does not mean that you may not have a growth restricted baby at 40 weeks. And that's, I think, the big concern is that, if we think the scans are fine and all looks good at that point, then it must be fine going forward. And of course, most of the time it will be, but that's not always the case.
And if you're talking about any point in time in identifying that fetal growth restriction, is the discrepancy between the AC and the EFW useful?
I think, the evidence here, the AC is probably the most sensitive marker of growth restriction as such. If the AC is small, you'd be more concerned that there's growth restriction rather than, and particularly if there's disproportion, if the head's sort of spared. But I think, again, those conventional teachings are sometimes, the placenta in the baby doesn't necessarily read the textbook. And so, I think, yes, it's helpful, but I wouldn't place, if the baby's small, the baby's small, and I think we should do sort of appropriate investigation and management. Wouldn't be, for example, terribly reassured by just because the baby's symmetrically small. That wouldn't make me think, oh, it's much more likely to be constitutional. I'd still be wanting to make sure there isn't other stuff going on.
And the third question was the sensitivity of a woman's actual perception. So a woman has had a baby before and says, look, I feel that this baby's smaller. Or in some instances where you keep actually thinking, oh, is this baby small? And she says, oh, all my babies were like that and they were all fine. Do we understand what the sensitivity of a maternal perception is?
Yeah, so the evidence would suggest it's actually quite good. And should be absolutely, if someone says they're concerned, they think their baby's smaller than their previous babies, that absolutely should merit, I think, further assessment. The converse, I guess, if they say that, I think I would still be concerned if we felt it was small clinically, because yes, maybe previously some people they don't, for whatever anatomical reason, they don't measure particularly big, they don't look particularly big, but they have a completely normal sized baby. And I think, again, yes, that is likely to be the case, but just being mindful that, every pregnancy is different, and this could be the one that, in fact, the baby is truly smaller and we wouldn't want to miss it. So,
thank you.
So, and as I was just saying before, so it is simply a snapshot in time. And of course, if you have multiple growth scans, you can get a sense of the velocity and how things have progressed in the past up until that point. But that doesn't necessarily predict future growth velocity. So, of course, if you have a baby on the 30th centile at 36 weeks, this can very easily become SGA as a product of FGR, so growth restriction, by 40 weeks. And so it's important, even if you've done serial scans, and often we wouldn't do growth scans much above sort of 37 weeks or so, because I guess the accuracy of them declines as well. And it's important then to continue clinical assessment of fetal growth after that last ultrasound. So not just assuming, oh, it was fine at 36 weeks, it'll be fine at 41 weeks. That absolutely may not be the case. And we've had a number of examples of, quite compromised babies born where the growth scan at 36 was fine, but then the baby came out really not having grown very much at all in the intervening time. And so highlighting the importance of that ongoing clinical assessment of growth. So this is a very brief summary of some of the diagnostic aspects of FGR. So these are obviously the core measurements we do. So most of us would use these 4 measurements, which then get plugged into a formula to give us the average volume of a baby, of a fetus, which gets multiplied by the average mass of a baby to give us the estimated weight. So lots of assumptions there. And that's why, it's at least sort of 10 to 15%, if not more, sort of margin of error in terms of estimating the weight of the baby. But if you have an estimated weight or AC under the 10th centile, so that's certainly estimated weight under the 10th centile is SGA. But if it's less than the third, then that's much more concerning for fetal growth restriction. If you have reduced LICOR, obviously as an indirect marker of placental function through renal fetal perfusion. Abnormal umbilical artery Doppler, of course, is a marker of placental dysfunction, non-reassuring CTG, and then fetal movements that we'll come to later as well. And so if we suspect FGR, obviously we identify it using ultrasound, which may give us clear evidence in terms of placental dysfunction, or maybe less helpful where you have a slightly small baby with normal LICOR and Dopplers, and then you're not quite sure, well, is it just sort of constitutionally small? Is it in fact growth restricted? Should it be bigger? And so that's where looking for a cause would be appropriate. Lisa has done, and this might come up in her talk potentially, but the utility of doing torch serology that has been done as an article of faith for many years in investigating small babies. The yield from that is very low. And I think I'll leave it for her to comment on that during her talk, but the yield is very low. So I think, but looking for preeclampsia is obviously very important. Developing a plan for surveillance where appropriate is critical. Initiating a planning for birth with a woman, so shared decision-making around timing and mode of birth. But also needs to include location. Obviously, in our tertiary centres, we look after women from many parts of the state, if not interstate. And so we need to determine, is it appropriate for you to birth in your local service or a service closer to home, or do you need to be with us in the tertiary centre? And sending the placenta for histopathology is really important because there are some placental pathologies that have a high recurrence rate and do merit specific therapies in future pregnancy that may reduce the chance of recurrence. And then that postnatal debrief is so important. It's, again, something that's very hard for us to achieve in the public system, but it's something we're very keen to work on, that 4th trimester piece. But again, this is where you as GP colleagues have such an important role to play. And if we can help support you in that, if you are seeing someone where there has been growth restriction, the placenta has been sent off, please let us know if we can help interpret that and provide guidance to the patient. Moving now to the other end of the spectrum, so large for gestational age. Definitions here are equally a bit variable. Generally defined as an estimated fetal weight or birth weight above the 90th centile, but again, it depends on which chart you use. Macrosomia is generally defined rather than a centile. It's defined as a birth weight of either greater than 4 or 4.5 kilos. And this clearly can only be diagnosed after birth, although we can, of course, suspect it before birth. Ultrasound has not performed particularly well in identifying macrosomia. It's got a sensitivity of 56% and a specificity of 92% for predicting birth weight of more than 4 kilos. So again, it's a bit similar to our clinical assessment of presentation. If we think it's big, we're probably right, but even if we think it's not so big, then it can still be big. What are the risk factors? So again, these are fairly self-evident. Diabetes is the one everyone thinks of, but certain ethnicities have higher bigger babies. Pre-pregnancy body mass index, prior history of LGA, being a little bit older, higher parity. Placentas tend to work better in subsequent pregnancies. If you've gone overdue, if you've gained a lot of weight in pregnancy, male infants tend to be bigger. And then there are, of course, relatively rare fetal overgrowth syndromes like Beckwith-Wiedemann syndrome. And again, why do we worry about this? So slightly, obviously, different risks to the small baby. So mothers have a higher chance of cesarean birth, shoulder dystocia, postpartum hemorrhage, and obstetric anal sphincter injury. And the babies, it's the shoulder dystocia that's the thing we're probably most concerned about, with clavicular fracture, brachial plexus injury, HIE, or death. Low 5-minute APGAR scores are linked to this, admission to the nursery, hypoglycemia, even if the mother's not diabetic. And then, of course, the developmental origins of disease concept that results in higher rates of obesity and metabolic syndrome in later life for the offspring. So these recommendations are taken from the RANSCOG guidelines from a few years ago, and they would suggest that the benefit of induction of labour before 39 weeks in the presence of ultrasound confirmed fetal, so they've used ultrasound to identify macrosomia, so estimated weight greater than 95th centile rather than the 90th, must be weighed against the challenges with the ultrasound diagnosis of a big baby, as I said, as well as the short-term and long-term outcomes for babies born before 39 weeks. And again, there's evolving evidence, as I'll show later, about the benefits of achieving greater gestation. And of course, the principles of shared decision-making should be applied in these discussions. And this is a recent Cochrane review that includes the French paper by Boulvin et al. That really sort of started to show the benefit potentially of induction from around 38 weeks for big babies in avoiding shoulder dystocia and the complications thereof. And you can see this almost crosses one, but not quite. So it does look like that sort of induction of labour does reduce the chance of shoulder dystocia when babies are thought to be big. And so this is something we're starting to do a bit more of, and this is any fracture is reduced as well. So these are, I think, outcomes that are important to parents. It's important that we discuss the option of induction with them and the risks and benefits of that. But I think these data and the studies that support this meta-analysis are compelling, and I think have altered our practice a bit, whereas previously we thought there was no point. And similarly, if we think a baby is very big, so in the absence of diabetes, if it's 5 kilos or more, or in women with diabetes, if it's 4.5 kilos or more, then offering a cesarean section is a very reasonable plan of action. Moving on to decreased fetal movements. This is a challenge. I find that this is a very, very difficult area. I don't have a clear, I find it very, very tricky. And the challenge here is that, I mean, clearly we have evidence that women who have had stillbirths or significantly compromised babies, many of them report a history, in retrospect, obviously, of reduced movements or a change in the pattern of movements. The challenge, of course, is that a change in the pattern of movements is very common. So it's one of the commoner reasons why women present in pregnancy. And most of them are fine, of course. And there is a distinction between the movements that are actually happening and the movements that are perceived. And so it's a very difficult area. There's no magic number. I think that there's no good evidence for counting kicks or number of movements in a particular time period. And that's why the Australian approach promoted by PSANS and the Stillbirth CRE have suggested not counting specific movements, but really just having an overall appreciation of the baby's general pattern of movements. And if there is a change in that pattern or a decrease in the strength or frequency of movements, they should come in and get checked. And that presentation to be checked should not be delayed through efforts to stimulate the baby by food or drink. And so the first thing you need to do is obviously make sure the baby's alive, so doing a handheld Doppler. But that isn't sufficient. We then need to do further assessment to make sure the baby's fine. So a CDG would be the standard after 28 weeks. Obviously, prior to that, it's a bit trickier and would normally require ultrasound. But also, regular movements often haven't established themselves before 28 weeks. And so I think a different approach needs to be taken there. But most of these presentations are in the 3rd trimester. And if someone has a normal CTG, no risk factors identified, and it was their first presentation, and the mother's comfortable with the movements she feels, then no further investigations required. But if those things don't apply, then you could consider doing a fetal maternal hemorrhage test, looking for fetal blood in the maternal circulation, ultrasound to assess growth and well-being, and then making a plan thereafter. And of course, birth planning needs to be individualized. And those who present with multiple episodes of reduced movements, obviously a higher chance of having an earlier birth. So there've been a number of studies looking at, well, what's the impact of encouraging awareness of fetal movement on stillbirth, for example, or other outcomes. And so this again is relatively recent sort of meta-analysis data, and doesn't actually seem to help. So we sort of increase into intervention. We do more when people come in because of reduced movements, but it doesn't actually certainly reduce the chance of stillbirth. And in these studies, in fact, it looks like you're better off not encouraging awareness. Now, of course, we can't do that. We know, even sort of anecdotally, that there is that relationship. I think we just need to put it into context and be reassuring, and not, I guess, encourage an obsession around movements, which some people do have. And you'd be aware that we've now banned handheld Dopplers because of these types of concerns. And so encouraging people to present if they're worried, but also just, I think, having a realistic appreciation of the nature of fetal movements and the challenges of interpreting them. So these are recommendations from Pazan's and the Stillbirth CRE. As I said, presentation shouldn't be delayed by encouraging people to drink or anything like that. We don't recommend kick charts. And maternal concern of decreased movements overrides any definition based on numbers of fetal movements. So there's very little evidence to guide that.
So Stefan, I
Yes.
find this area very difficult too, and it's a very evolving area. We do tend to change. We started off with kick charts. I tend to actually suggest to women that in the third trimester, they, at some stage during the day, they just sit quietly and get to know the movements of their baby, and therefore actually understand the pattern of their baby. And if that changes to present, is there any evidence to suggest that that's valuable, or is it just me feeling good?
No, I think that's a very sensible approach. I don't think we have good evidence. I mean, no, I think the evidence would in fact would suggest that we don't encourage awareness, but I think that doesn't sit well with any of us. Like because if one person is encouraged to come in, and and we've all in our careers had that one person who came in with reduced movements and the CDG was dire and they had a seizure and the baby was fine, and you thought, well, if if it had been another whatever, it could have been a very different story. So I think that approach is very reasonable. I think just gaining that appreciation of what is your baby's sort of pattern of movements, and if you are concerned, it's a bit like the castle. It's the vibe of the thing. If you're worried about, which is so vague, and we feel so it's so difficult having conversations with women saying, if you're worried, just come in. Well, I mean, some people understandably are worried the whole time, and it's. I just don't think there's an easier answer. I think what you've described is very sensible.
Yeah, and I think that's a very honest answer too. So thank you very much, Stefan.
Yeah, and I think don't ever hesitate if you're seeing someone you're worried and they're worried. Just ask them to come in. It's very easy for us to assess them, and we're always happy to see people, of course. So turning now to cholestasis of pregnancy. This is characterized by itch, that's the cardinal feature, elevated transaminases, so liver enzymes, and elevated serum bile acids. It's the most common pregnancy-specific liver disorder. The incidence varies widely with geography and by season. So some parts of South America have huge rates. It's more common in those with pre-existing liver disease, such as hepatitis C. And so for those who have particularly sort of early onset severe ICP, we would do an investigation to make sure they don't have associated liver disease. Ultrasound of the maternal liver in women with ICP alone is completely normal. So if anything is found on liver ultrasound, it's not ICP, it's something else. And the onset is generally in the second and third trimester. You can have it in people with like sort of similar sort of syndrome in the first trimester after IVF and things, but generally it's an issue later in pregnancy. So a key point here is that bile acid should be assessed non-fasting rather than fasting. If you do them fasting, so that should be maybe artificially low if fasting, not if non-fasting. So if you do them fasting, they might be artificially low because they haven't been stimulated, I guess. So you should do non-fasting bile salts. ICP is not associated with a rash or skin lesions apart from scratch marks and excoriation. So if there is a rash, it's not ICP that's causing the rash. Now, they might have ICP and a rash, but the rash is not ICP. And the cardinal feature of ICP pruritus helps distinguish this condition from other causes of elevated transaminases in pregnancy, like HELLP syndrome and things like that. So if someone's got has transaminases that are elevated, but they don't have an itch, then it almost certainly is not cholestasis. Well, at least cholestasis in pregnancy. They might have some other cholestatic issue going on, but not ICP. So what are the risks here? Well, one of the main risks is that we get babies out very early because we're worried about it. There's an increased risk of spontaneous preterm birth, increased risk of meconium state amniotic fluid, neonatal care, nursery admission, and increased risk of stillbirth, which is, of course, the concern we all know about so much. And these data are a little bit old now, but I think very nicely describe and demonstrate the relationship between the bile acid concentrations and the chance of stillbirth. And so you can see that, so this is sort of divided into mild, so 0 to 40 bile acids, moderate, so 40 to 100, and then severe, 100 plus. And these are peak bile acids in any point in the pregnancy. And you can see there's a very clear jump. It's like there's a massive jump here between 99 and sort of 100 and above. And so there's a threshold there above which the rate of stillbirth is appreciably much higher. And this is the population that we really need to be focusing on, less so these who really probably have outcomes that are broadly comparable to the general population. The mainstay of therapy is ursodeoxycholic acid, or UDCA. Consistently reduces pruritic scores, so itch scores. It improves bile acid and transaminase levels. There's a trend towards fewer stillbirths and preterm births, although the studies haven't been quite big enough to demonstrate that conclusively, and no known adverse fetal or neonatal impacts. It can be very expensive. Arranging prescription through the public hospital pharmacy may be more cost effective for patients, and that's a very reasonable, reason to send someone in to access cheaper medication. We're doing a trial currently. So this is led by Bill Haig, an obstetric physician in Adelaide, who's been a long-standing, very significant contributor to our knowledge in this field, along with his international colleagues. And so this is looking at the potential role of rifampicin, either in addition to or instead of ursodeoxycholic acid to improve outcomes. And so women who are certainly coming to the women's, and I suspect other hospitals in Melbourne are signed up to this trial as well, are offered participation in this study as well. So these are data from the Royal College in the UK, also guidance from the Royal College in the UK, and sort of based on that data that I presented before. So if you have bile acids that peak up to 40, then no other risk factors, then the risk of stillbirth is similar to the background risk. If they're up to 100, between 40 and 100, and no other risk factors, then the risk of stillbirth is probably similar to the background risk up until 38 to 39 weeks. And so planning birth around those gestations is reasonable. Whereas if your peak is above 100, then the risk of stillbirth is higher, and you should think about doing something a bit earlier. Now, the UK tend to push things later. The Americans would be earlier than all of this. They would be doing things at peak bile acids of more than 100 to sort of much less than 35, sort of closer to 34, 33-week mark. But I think those data are quite nice and clear, and I think this is a very reasonable approach to take as well. But obviously there's nuance, and part of the issue, of course, is the maternal condition, and the itch is at times absolutely debilitating. And so that in itself can be a reason to think about getting a baby out earlier as well for maternal mental well-being.
There's quite a bit of evolution there in the last few years, isn't there, with regards to, if it's not so high, the risk of stillbirth's not as high as we once thought. So that ability to wait on and just monitor. The other question that's been asked is, how early does intrahepatic cholestasis actually happen?
So it's generally, it's unusual for it to come on prior to the second trimester. Like, it technically can. But I mean, normally it's third trimester and occasionally second trimester, but I guess it technically could come on even earlier than that. But if that were the case, you'd really want to be investigating other potential sort of causes or concerns. It's generally a second to third trimester diagnosis. But we have had some people with severe early onset ICP who've been quite unwell with it.
The cases I've seen where it's been quite severe have been women with chronic hepatitis C usually.
Yes, exactly. Yeah, so if you've got pre-existing liver disease, you're at risk of having things earlier on, and more severe. Moving now to pregnancy hypertension. As I promised you, this is a whistle-stop tour of the greatest hits of the third trimester. So this list of recommendations is from the recently released SOMAN's Hypertension in Pregnancy Guideline. Now, I'm very biased here. I have the privilege of serving currently as the president of the Society of Obstetric Medicine of Australia and New Zealand. I didn't have anything to do with this guideline other than to provide moral support to those who did a superb job bringing it together on the smell of an oily rag. I think it's absolutely the cheapest NHMRC endorsed guideline in existence, and they have done a magnificent job. So I think if you are a connoisseur of fine guidelines, I would strongly recommend looking it up because it is just so nicely done. And it also happens to produce, provide really helpful clinical information as well. So it's well worth it for lots of reasons. But this is their top 10 recommendations. So just going through them one by one. So if you have hypertension in pregnancy, which is still diagnosed as greater than or equal to 140 on 90, you should look for what is causing it. Is it pre-existing? Is it preeclampsia? Is it gestational hypertension? And those with white coat or hypertension are still at higher risk of having problems. So it's still important to assess exactly what's going on there. Don't just put it down to being white coat. All women should be assessed in the first trimester for their risk of developing preeclampsia. You can get a better sense of this risk by doing combined screening, which includes uterine artery Doppler assessment at the time of the nuchal scan and looking at some biomarkers. But even just taking a history and taking your blood pressure can help you gauge the risk. If someone is thought to be high risk, then starting aspirin, 150 milligrams at night before 16 weeks, and possibly calcium as well, and doing some exercise will make a difference to their risk. We should use urine protein creatinine ratios to assess for proteinuria. Dipsticks are not particularly reliable. And unfortunately, I think we've all largely stopped doing 24-hour collections because they were very challenging for everyone. The angiogenic biomarker test, so this is the SFIT, soluble FMS like tyrosine kinase 1, PLGF, placental growth factor ratio, which is available at the Women's through the lab at the Children's. This is a predictive biomarker that can help rule out preeclampsia. Its major value is in exclude or minimizing the chance of the diagnosis in 1 to 4 weeks after the test. It's not yet used for the diagnosis of the condition, and it doesn't really help. I mean, it can potentially help us predict delivery outcomes and timing of birth, but we need more data to guide us there. And those data sets are evolving all the time. Women with gestational hypertension or chronic hypertension we should be aiming for a target of less than 135 on 85, and there's good recent data to show that tighter control improves outcomes. Home blood pressure monitoring or ambulatory assessment can be used to diagnose white coat or masked hypertension, and this is appropriate. Women with preeclampsia should have their babies around 37 weeks or thereabouts, or a bit later. Less than 37 weeks, ideally, depending on the severity of the condition, you try to give it more time, particularly if they're at a gestational window where steroids would be of benefit, so less than 35 weeks. NSAIDs should be avoided in the immediate postpartum period, and if you need to use them at the lowest dose for the shortest time possible for women with preeclampsia. And women should be informed of the longer-term risks associated with a hypertensive disorder of pregnancy. And I think this is a big area that I'll come to here. So lots of data to show that these women are at significant increased risk, not just of hypertension, but of broader cardiovascular disease and indeed metabolic disease as well. So routine sort of annual or thereabout screening, looking for these problems, I think is reasonable. So many of our cardiovascular risk tools are based on, I guess, sort of risk factors that are found in white men. And whereas preeclampsia is a condition, I guess, that is, of course, unique to women. And so as a way of improving the identification of cardiovascular and metabolic disease in a population that has historically had less favorable outcomes in identifying and managing cardiovascular disease because of the, I guess, the focus on the male presentation. And these data are this table is very helpful from the guideline showing the agents to use. Now, again, you'd doubtless be aware of the challenges we've had recently around immediate release nifedipine that is now no longer available through the usual channels, and you need to use the special access scheme to get it, which is somewhat cumbersome, and the shortages of labetalol. So, and that's because we only really have 6 antihypertensives we can use in pregnancy as against the 40 to 50 in the non-pregnant population. So this is a big issue, and I had the privilege of preparing an MJA perspective paper with some other SOMANS members recently, really just going through the challenges of pharmaceuticals in pregnancy and the very significant disadvantage they face because of their exclusion from clinical trials. The outdated categorization system, ABCDX, is really not very helpful. And then the problems with a sponsor-driven model where it depends on a drug having a profit margin for it to be brought into the country and used. And obviously this is a small population in a small population at the end of supply chains in the world. And understandably, pharmaceutical companies who have a profit motive are not going to find it particularly appealing to import an off-label, off-patent drug that isn't going to make them much money. So we need an alternative approach, I think. Finally, induction of labour. What's new? So there's an increasing trend towards outpatient cervical ripening with balloon catheters. This has resulted in a reduced composite adverse perinatal outcome in meta-analysis, so we're doing more of that. We also now have low-dose misoprostol. Again, misoprostol is old and cheap. It's been around for a long time. Unfortunately, these tablets are not old and cheap. It's the same drug, but it's been packaged together in 25 microgram tablets by the drug company and is now sold at many more times the price of the 200 microgram tablets. So somewhat a cynical approach, but anyway, it's available. And we're starting to use that here at the Women's. And there's evidence to show that this in combination with a balloon catheter leads to really quite favourable outcomes with induction with lowest time to delivery rates, timeframes. Again, just coming to this concept of the timing of birth. So for most women, planned birth can be delayed safely until 39 weeks. I mean, there is such an evolving body of evidence to show the benefits of this for the baby. And you really need a good reason to do something before then. Social reasons alone, unless they're really extenuating, are not sufficient, I don't think. The WHO recommends induction of labour by 41 weeks. Most of our hospitals, because we can do extra monitoring, will take that a few days more, so often 41 and 3, which is reasonable. I think getting much beyond that is when the risk of stillbirth goes up. And this was a Swedish study, again, sort of showing that if you went beyond 41 weeks, you do have an increase in the perinatal death rate. And the number needed to treat to avoid one perinatal death is 230. So sizable numbers, but again, we're in the business of preventing rare but catastrophic outcomes. What about 39 weeks for everyone? So you'd be, again, well aware of some of the research that's been published recently. So meta-analysis published by a team at the Mercy recently showing the potential benefits here. And these have generated significant media interest. And of course, the ARRIVE trial that was published back in 2018, looking at sort of low-risk primiparous women and the potential benefits of induction of labour. And in fact, the primary outcome was a composite perinatal death or severe neonatal complications, and there was no real difference. I mean, slightly didn't reach significance. But the interesting point that everyone's latched onto is that the frequency of caesarean delivery was less in the induction group. And so there's sort of a significant difference there. And so that's what everyone sort of grabbed hold of. And this has actually borne itself out in population data. So these are data from the US, from the whole country, after the publication of ARRIVE. And you can see that the induction of labour rate has gone up significantly. And if this were, part of the cascade of intervention that resulted in sort of increasing caesarean rates, you would expect the caesarean rate similarly to go up, but in fact it has. And it's a bit of an eye of faith thing. If you squint hard enough, it looks like it's actually gone down a bit. So I think these are reasonably compelling data to show that induction of labour in and of itself doesn't actually push up the caesarean rate. However, these studies have generated considerable debate. There are significant resource implications in applying these findings, and we really need to develop consistent approaches to requests for induction of labour at 39 weeks without a specific indication. The key is to avoid births prior to 39 weeks in the absence of a clear medical or obstetric reason. I think that's the crux of it. And then how we deal with the rest of it is something that we'll manage over time. So that was that from me. I'm very happy to take questions, Inez.
Thank you. Yes, thank you. I've asked some of the questions along the way. That was such a terrific presentation, Stefan. I've got a few questions around cholestasis. So if you've got a small, firstly, I thought it was fasting
Yep.
bile acids. Yes, thank you, because I think
So
that there was
non-fasting.
there was a mistake. It's fasting or non-fasting?
Sorry. So better to be non-fasting. So yes, there was a typo in the slide. I'm sorry. So non-fasting is better because if they're fasting, they might be artificially low because they haven't been stimulated, I guess. So studies would suggest they're better off being non-fasting. So it's easier for patients as well.
Much easier. Also, thank you for that. And for anyone that I wrote fasting, that was a mistake. It was non-fasting. The other thing is, if there's a slight increase in bile acids, when and say normal LFTs, when would you usually repeat it?
And the patient has symptoms.
Mm.
I think, and normal LFTs, look, I think sort of depending on the gestation, but 2 weeks would be reasonable. 1 to 2 weeks would be fine.
And once you really diagnose cholestasis, so I was saying it really transfer over to hospital care and out of shared care. That would be my expectation.
Yeah, generally, I think, yes, we would be very happy to look after these patients.
There's a question about the size of baby versus the size of a woman. So the question was, if you've got a 150 centimetre woman and you've got a 4 kilo baby, do you do the alteration? But I suppose that also gets to the question of me of, where is that point in a woman's height where she's much more likely to have not be able to have a successful vaginal delivery? We used to traditionally say 150 centimetres, but again, I don't know what the evidence is around that.
Look, I think it's a continuum. I don't think there's a threshold as such. I'm not aware of any really good evidence. I mean, there is certainly clearly an association that, a greater maternal height is associated with a higher chance of vaginal birth and shorter stature. But again, it depends on, I guess, paternity and on fetal size and so many factors. I think it's, I mean, yes, but if you had a woman of particularly short stature and a big baby, then I guess your thresholds would shift as to recommending either potentially cesarean or a slightly earlier induction of labour to try to avert the concerns associated with having a bigger baby. But I think that needs to be individualised and nuanced. I think it's very difficult to make sort of general comments there. But again, that's where I think that's what, I mean, there are so many advantages, obviously, of shared decision-making, but one of them is that we can be honest about those things about which we, just don't know. Like, the unpredictability of things and being clear about the fact that there are things we don't know what's going to happen. We don't know, what's going to occur.
It's the beauty of looking after someone in pregnancy. You see them multiple times, so there's conversations you revisit and you grow on.
Precisely, and particularly in shared care, where you have that continuity. And it's one of the great advantages, I think, of the shared care model is that you know someone well, and particularly if you've known them before the pregnancy, then you really know their values, what's important to them, and the communication, I think, can be very obviously very effective.
And very deep, I think, too. There's a question about abnormal LFTs, and I think that they tend to settle quite quickly post-pregnancy with cholestasis. So if they don't settle, I would say look for something else. Would you agree, Stefan?
Yes. Well, some of them do take quite a while to settle, but yes, I mean, we certainly investigate further. And then the question that's often raised then is, what about the combined pill if someone's had cholestasis before? So the traditional teaching is you would never use it, but in fact, lots of people do go on it and are fine. They don't have a recurrence of the symptoms. But if they have had a recurrence of symptoms with the pill, then obviously continuing using it wouldn't be such a good idea. So it's not an absolute contraindication, but it's probably still, if there's something else they could take that they'd be equally happy with, then it's reasonable to avoid.
And my last question is, just if someone's had preeclampsia or pregnancy-induced hypertension, how long would you avoid the non-steroidals for post-pregnancy, post-birth?
Yes, I think, well, the nephrologist would say forever. I don't think that's particularly, I think, look, the first week or two, I mean, I probably, avoid them during the time that they would be most useful would probably be the unfortunate thing. So, the first week after birth would probably be a good time to avoid them. After that, when, the renal function is probably improved and everything else is better, then probably not so much of an issue. But, look, in practice, I think unless someone's got particularly, deranged renal function, we do tend to use them a little bit because they're highly effective analgesic agents. But yes, I think normally for the first week.
I'll just take 2 questions which I get quite often, which is somebody who's going post-term after 41 weeks. Sometimes women really do want to keep going until they actually go into natural labour. Is there a point where, and we tend to do CTGs, AFIs every few days, did that really give us comfort, or is it useful? It's useful if it's abnormal, but is it useful if it's normal to say you're okay to keep going?
I think it still does. I like it after a normal CTG in the absence of, abruption or bleeding or something else. It is reassuring for the next 24 hours or so. So I think it's helpful to do. I think the strength of evidence for that is, I think it's can't pull the numbers off the top of my head, but I think it's reasonable. I think it's a very reasonable thing to do. And certainly if you didn't do any of that, we'd be much more concerned about missing evolving, placental dysfunction and then sort of missing the opportunity to act. And certainly, the very late post-date stillbirths that we see, which are not all that common, but often they are also, or generally, in fact, they are in women who have declined additional monitoring as well. We don't see them very often at all in women who've had additional monitoring and have accepted intervention if the monitoring is abnormal.
Look, there are so many more questions to ask here, but I think I'll have to leave it there to go to the next fascinating talk, which is Lisa's. So thank you very much for those questions. We'll try to grab some of those questions and answer them perhaps in an email out to the group.
Yeah, I'm very happy to do that. That'd be great.
That'd be fantastic because there's some great questions there. And Lisa, I might let you drive if that's easier for you, but I'll introduce you. So Stefan, again, that was fantastic. And Professor Lisa Hui is a maternal fetal medicine specialist at Mercy Hospital for Women. She has a special interest in prenatal screening and diagnosis and is the hospital's Director of Genetics, a clinical academic in the Department of Obstetrics, Gynecology and Newborn Health at the University of Melbourne, and Group Leader of Reproductive Epidemiology at the Murdoch Children's Research Institute. Lisa is an active member of the International Society for Prenatal Diagnosis and an Associate Editor of the official scientific journal, Prenatal Diagnosis. Thank you and welcome, Lisa.
Okay, thank you, Inez. And thanks for that great talk, Stefan. Certainly did cover the top hits of the third trimester, so I'm going to try and do the same for perinatal infections. It says I can't share at the moment, Inez. It still says it's disabled.
Stefan, could you stop sharing? Perhaps you have already.
I've stopped, Inez.
Yeah.
Oh, okay, so that's all right. Someone's just made me the co-host. Okay, so now it should work. Now, what can you all see?
All I can see is double. Oh, now you're right, but you said
okay.
Into screen showing.
Sure.
Slide.
Okay, so can you see the correct display, or are you seeing this presenter view?
I'm seeing the presenter view. So
okay. Does that help? Yep, that's better. Okay. It's always a little bit nerve-wracking. You never know exactly what you're going to share with the entire crowd when you do this. That's why I was cleaning up my desktop. Well, thank you for that introduction. And again, it's very nice to be here and to have the chance to talk with all of you who do so much work for our patients, and we don't really have enough contact and communication, I think. So this is a great opportunity to share some more recent information and flag some possible changes that might be coming up in antenatal care, and of course to answer your questions. So when I was asked to do this topic, it was a little bit hard to work out how broad to go, and I decided rather than trying to cover lots of infections very quickly, I would just focus on three that I think are important and have something interesting to share with you at the moment. So I think one of the interesting things about perinatal infections is what women are conscious of is actually often quite different to what we're thinking about. And this slide comes from UK government parent information website, and these are the top frequently asked questions they get about potential environmental harms to a baby. And you can see that infection certainly is very top of pregnant women's minds, but actually they're thinking about probably two of the rarest perinatal infections that can cause adverse pregnancy outcomes. So listeria and toxo. Everyone seems to be very aware of what they can and can't eat. Everyone seems to be afraid of cats. And so you would think that, these are the two most dangerous things that can affect fetal development. But actually, the reality is quite something different. So today I'm going to talk about congenital cytomegalovirus, CMV, because that is actually the most common congenital infection in our community. I'm also going to talk about syphilis because there's an epidemic at the moment around the world and also in Australia. And I think it's just something we need to refresh ourselves about and to remember to think about if we see something out of the ordinary or have someone with risk factors. And then the third infection I'm going to cover today is parvovirus. There's actually a European epidemic, and I recently attended a conference in Budapest, and all our European colleagues were remarking on how much parvovirus infection they've seen this year and how many fetal transfusions they've had to do for fetal anemia as a consequence. So we've seen a couple of cases this year. It probably isn't an epidemic, but I think given the way the world travels and how small the globe is today, it's something we need to remember to think about if we have someone who's been exposed. So I'm going to start off talking about cytomegalovirus, and I'm going to start with a case history of a patient who came to the Mercy Hospital for Women earlier this year, and these images are shared with her permission. So she's a 35-year-old woman having her second child, and she presented with reduced fetal movements at 36 weeks gestation, and the pregnancy up until that time had been completely uncomplicated. She just so happened to turn up when the ultrasound department had the capacity to do a growth scan for her, and they had some very unexpected findings, particularly in the fetal brain. So she had not had a scan since her normal 20-week morphology scan, and unfortunately at 36 weeks there was cerebral ventricular megaly and some specific findings that are very characteristic of congenital CMV infection. So there were septations within the cerebral ventricles, which are kind of sequelae of inflammation and necrosis. There was also abnormal sulcation. Let me see if I can put a pointer up. Not sure how to, hold on, I'll try and do that in a sec. And there was also a lot of extraaxial space, which suggests brain atrophy, and abnormal fetal Dopplers suggesting fetal anemia. So this was obviously very unexpected, and we met with her on that day, and also she met with our neonatologist to talk about the findings. She actually had multiple consultations with us over the course of the next week with this information to sink in, and the ultrasound findings were really enough for us to consider congenital CMV as a top diagnosis, and testing of her serology and retrospective testing of her serology at booking showed that she had indeed had a primary infection in pregnancy. And with these brain findings, there was a high risk of severe disability. These are images that were taken during that week. The Dopplers there of the middle cerebral artery show features of fetal anemia, so the blood is flowing very quickly. There's a high peak systolic velocity in the middle cerebral artery. That's a hallmark of fetal anemia. And the liver was also enlarged with some focal calcifications, again, very typical of congenital infection. She had a repeat cesarean section at 37 weeks, and the baby looked very much like this baby, which whose images I've taken from the Centre for Disease Control from the US, but the baby had the very similar appearance of jaundice with the blueberry muffin appearance. See these little blue nodules? They're actually regions of intradermal hemopoiesis, and that's a consequence of that really severe anemia. And a very abnormal neurological exam. The baby hardly moved at all, had an absent suck, absent gag, and the severe CNS abnormalities were confirmed on ultrasound. The baby had comfort care and passed away on the first day of life. These are images from the ultrasound that was done in that on that first day. There's ventricular megaly, so the black areas are fluid, so the cerebral ventricles here are abnormally enlarged, and on the right image. I'm just trying to see how I can get a pointer up here. So this is the lateral ventricle, sort of parasagittal view, and in the posterior horn here, in the occipital horn, there's a big kind of cystic space there. So, of course, this was absolutely devastating news for the family. And I think one of the hardest things for us is actually explaining to a woman that it's caused by an infection that they've never heard of. And this woman had never heard of cytomegalovirus. She wasn't aware that it could cause harm, and she'd done everything she was supposed to do in the pregnancy, had all the tests, looked after her health, but still had this tragic outcome. So cytomegalovirus it infects the fetus via hematogenous spread and transplacental infection, and it is often silent, and that's why it's such a difficult condition to address. It actually occurs in, well, congenital infection, that is a baby born with CMV infection. It occurs in about 1 in 200 infants in high-income countries, which sounds very common. And the reason we were not that aware of it is because most of these babies actually are completely asymptomatic and don't suffer any long-term health outcomes. But about 10 to 15% will have long-term complications such as hearing loss, developmental disability, and cerebral palsy. And because these sorts of symptoms don't occur until a child is several years old, then all of us who work in the maternity sector don't see the consequences of these infections in pregnancy. And then when children present later with developmental disability or cerebral palsy, it's often too late to make that retrospective diagnosis. And unlike a lot of other congenital anomalies and developmental problems, prevention is actually possible in pregnancy. And there are several different ways to approach it. And I'll just talk about the ways that are kind of in our scope of practice as maternity clinicians. So just a reminder about what CMV is. It is a member of the herpes virus family, and I think that's really useful because it kind of just, like many of the other herpes viruses, it has the features of being asymptomatic usually when it's acquired, and then it sets up lifelong latent infection in the host. So it's just like herpes simplex, varicella zoster, and EBV. And it's also able to be reactivated, and people can shed this virus intermittently without knowing. So very much like the other herpes viruses. Congenital CMV is caused when a woman has an active maternal infection during pregnancy, and it infects the placenta and crosses to the fetus. And we divide this into primary infection and non-primary infection. Primary infection occurs when a woman who's never had exposure to CMV before is infected for the first time in pregnancy. So she seroconverts from CMV IgG negative to IgG positive during pregnancy. That's kind of a definitive diagnosis of a primary infection. But there's also an entity called non-primary infection. So like herpes simplex, you can get reinfected with a different strain. You can also have reactivation of your latent infection. That's non-primary infection is incredibly hard to diagnose, and it's usually something we only diagnose retrospectively after finding an affected fetus. The overall seroprevalence of women of reproductive age in Australia is not very well known. This data here is kind of about 20 years old now. It's from New South Wales, but it does show that the seroprevalence rate, the rate of women who've had CMV before they fall pregnant or before they reach their 30s, which is when most people are having children, is about 50 to 60%. And you can see there is a bit of a jump in the seroprevalence from the early 30s to the late 30s. And I suspect that's because women in their 30s are exposed much more commonly to common sources of infection, which actually happen to be young children. So children, unfortunately, are very common sources of infection for pregnant women because they catch viruses at daycare, playgroup, and when they catch CMV, they shed it for a very long time, and they shed lots lots and lots of it, and they have very poor self-control with their body fluids. So that's kind of where most of the infections are thought to arise from. So parents with a child under the age of 3 and childcare workers are considered to be at risk of CMV exposure. Fortunately, healthcare workers, we have the same risk as the general population. So if we're seronegative, the seroconversion rate is about 2 to 3% per annum. And that's because we practice universal precautions. So you really do need that infected body fluid to touch a mucous membrane for it to be transmitted, just like other herpes viruses. But it's not transmitted through respiratory droplets, so it's not as infectious as varicella. So the most important primary prevention strategy for congenital CMV is actually educating women about the existence of the virus, how it's transmitted, and how they can reduce their risk of infection. There's, as you can probably imagine, it's not the easiest intervention to do a very high quality randomized controlled trial about, because you can't ethically withhold information about CMV to one group and provide it to another group. But there has been a meta-analysis of what is out there in the literature. And they did conclude that preventative measures, and that means education about hygiene-based behavioural interventions, is acceptable to pregnant women. It can impact their behaviour and does have the potential to reduce the rate of CMV infection in pregnancy. Because we're talking about altering behaviour, in the family, asking people to change the way they interact with their children, there is obviously some resistance and some concern about the sort of response we would get when we start to talk about, reducing the risk of infection and minimising contact with infected body fluids from young toddlers. So the Cerebral Palsy Alliance have been doing a lot of public health work on this and a lot of work on the education message, because for them it's a high priority, because it's one of the few preventable causes of cerebral palsy. So they have a very nice CMV resource hub on the internet, with a whole lot of free resources that GPs can order, like posters for their waiting rooms, pamphlets to give to patients, and there are links. If you send like an information pack via email, you can provide these resources, and there are videos as well. So they've distilled the hygiene message into these 3 things: wash with care, kiss with care, and don't share. So washing with care is really about hand hygiene after being in contact with urine or saliva of young children, like changing nappies, or particularly wiping runny noses, and after handling dummies. Kiss with care is recommending or suggesting that people kiss their toddler or their child on the forehead rather than on the mouth. We can't always control where a toddler wants to kiss us, but we can at least be mindful of avoiding kissing children directly on the mouth while pregnant. And then don't share means not sharing food or cutlery or toothbrushes that have been used by children. So not putting something that's got child saliva into your own mouth. So yeah, there's lots of good reasons not to hoover up your toddler's leftovers, and this is another one. Okay. So RANZCOG do have a statement on the prevention of congenital CMV, and they do support the approach of giving women information about how to reduce their risk of CMV, and that it should be information provided to all women, regardless of whether they've had CMV or not in the past. And so that's where RANZCOG currently stands with its advice. But we know we're not particularly good at this. We know as busy doctors, we're not very good at the talking interventions, like prescribing medications or recommending a cesarean, but we're not so good at just the conversation, because we're very time poor. So And also knowledge and confidence is an additional factor. So we did this survey in 2015 of obstetricians, GPs and midwives in New South Wales and Victoria. And we found that less than 10% routinely discussed CMV prevention with their pregnant patients. And a survey that Antonia Shand and her group from Sydney performed showed that only a minority of women, 1 in 6, had ever heard of CMV, and a significant proportion regularly engaged in what we would consider risk behaviours for acquiring the infection. So since then, there have been a lot of resources developed to help support clinicians in providing education to pregnant women. And this is, I can highly recommend this 2-minute video that the Cerebral Palsy Alliance have on YouTube. I'll provide all the links to everyone afterwards. And we've recently just evaluated this message because a lot of people are concerned that the message may not be acceptable. So this was a survey that was around Australia. 73% of the women who participated had not received any education about CMV before. They're all pregnant. And the video was very successful at improving their knowledge and also creating a motivation to adhere to the hygiene advice. So they did feel it was very important. 81% felt informed afterwards. 41% did feel worried. And from the free text responses, many of these women were worried because they were having their 2nd or 3rd baby and no one had ever told them about this, or they were in 2nd or 3rd trimester and felt that they should have had that information earlier. But almost all of them thought the information was important to know. So I think we shouldn't feel too paternalistic and feel like we need to protect women from information about this virus. We just need to have the right way to do it that balances information with creating anxiety. So as I said, I'll share links to videos and these resources which provide very helpful suggestions for language around this. So one of the important messages really is that primary prevention is something that we should be providing to all pregnant women in early pregnancy, because first trimester is the key period where we want to avoid infection, because that's has the highest risk of complications for the fetus. And at the moment, we are not recommending routine serological screening for CMV. So this is again a snapshot of the current RANZCOG guideline. It is due for a full revision next year, and I know it's planned to undergo an evidence-based review. So there's some emerging evidence from Europe and Israel that actually might mean there might be some changes to this. So over the past 3 years, there's been some very exciting information coming out showing that if a woman is diagnosed with a primary CMV infection in early pregnancy, so around the time of conception or during the first trimester, you can actually stop the infection passing to the baby by giving the woman high-dose oral valacyclovir. So you have to diagnose the infection first in the woman, typically with serology, and as soon as possible, prescribe valacyclovir. Isn't a small matter though, because 8 grams a day is actually very high dose. It's 16 tablets a day, but when given in that dose, it significantly reduces the rate of fetal infection as diagnosed by a positive amniocentesis for CMV. It significantly reduces the rate of neonatal infection or infected newborns at birth, and it also reduces the rate of termination of pregnancy due to CMV-associated severe fetal findings, such as those brain findings that I showed in that case earlier. So all of these are very important findings, and it's the first time we've had something that's been shown in a randomized controlled trial to be efficacious. Importantly, you have to start the treatment as early as possible, which makes sense. You want to get the antiviral in before the virus has had time to establish infection in the placenta. And the window that's been established by these studies is within 6 weeks of the maternal infection. And importantly, there are some severe maternal side effects, including reversible acute renal failure in about 2% of patients, because that high dose of valacyclovir can end up causing, can crystallize in the renal tubules and cause reversible renal impairment. So we need to monitor maternal renal function as well as blood count, because it can cause cytopenias as well. So it's not something to be initiated in primary care. It's certainly definite tertiary hospital intervention, but it's important that you're aware that this is really recent changes in clinical practice. So a group of European experts have recently published their own consensus guideline, and they're recommending, now that there's a proven intervention to prevent fetal infection, they're recommending that all women actually now have serological screening in the first trimester so that these primary infections can be detected. As I mentioned, these infections are usually asymptomatic or have mild symptoms similar to the common cold. So if we're going to try and screen and treat to prevent fetal infection, it would require a lot of serology. And then in women who are confirmed to have had a primary infection in first trimester, they're recommending that valacyclovir be administered. So that's Europe, where they have a lower rate of their population seroprevalence of CMV is probably a little bit lower than our setting. So from a public health perspective and a cost effectiveness perspective, it does make sense for countries such as France to do this, but certainly not all countries are taking this advice from that consensus document. We thought we'd have a look and to see what GPs are currently doing here. So this is our referral base to the Mercy Hospital for Women. We did an audit of consecutive referrals over a 2-month period in 2020 and found that 14% had had CMV serology done with their booking bloods. So these are women who didn't have symptoms, who weren't being referred for a CMV infection, but had CMV serology with all of the other bloods submitted with the referral. Of these, 43% were CMV IgG negative, and this was significantly associated with being born in a high-income country, living in a high socioeconomic postcode, and being in the first pregnancy. So that actually fits with the demographics from other populations. It's actually the high socioeconomic status women, English-speaking, highly educated, who are more likely to be IgG negative. So that's, I guess, the hygiene hypothesis. These are people who haven't grown up in environments where there's a lot of circulating infectious diseases. So from this, we concluded that without any changes to our current screening practice, we're not asking GPs to do routine screening by any means, but without any changes, there are about 25 women a month who are referred to the Mercy who would be susceptible to primary infection. So we've just started a pilot study just looking at the feasibility and the acceptability of screening and screening for CMV in first trimester. So again, just to make sure the message is clear, we're not asking you to screen for CMV routinely, but we know that because some of you are, we need to offer those women who are IgG negative some education, and we're offering them a follow-up blood test at 12 weeks to see if they have seroconverted and acquired CMV in first trimester. So our research team are screening all the referrals. Those women who are IgG negative are contacted by phone, and we have discovered that it is remarkably hard to contact people on a mobile phone if you're coming from an unknown number. People are very suspicious. But of the women we do reach, over 80% are quite happy to participate in this pilot study. They're given information, regardless of whether they consent or don't consent. We give them all information about how to reduce their risk of CMV infection. And happily, of the 42 who've got to 12 weeks and had their repeat testing done, all of them have remained CMV negative. We've also tested them for anxiety using validated scales, and there's no increase in anxiety, and over 90% of them were satisfied with participating in this screening protocol. So we're going to continue recruiting till the end of this year and share the results, but that will help us, I guess, moving forward, trying to understand whether routine screening is going to be something that Australians, the Australian population should adopt.
Thank you, Lisa. It's a very murky field and it's a developing field. I'm getting lots of questions about it, but two I'll ask in particular, which is if somebody is, I know we can get reactivation as you've described of CMV, but if somebody is IgG positive and IgM negative, if you have done routine screening, like 14% of GPs that do, can you give them some assurance that they're at less risk?
Yes, they are at lower risk. So we think the risk, it's very hard to ascertain, but the chance of the fetus being infected if a woman gets a non-primary infection is only about 1 to 2%, whereas if a woman who's seronegative gets infected, so primary infection, the risk to the fetus is about 40%. Yeah.
And is
so
the risk of severity worse also for primary infection versus reinfection?
No, actually it's not. It's actually about the time that the fetus gets infected. So it doesn't matter if it's a primary or non-primary infection. If it's in the first trimester, that's the period where the fetus is vulnerable. And if the fetus gets infected in second or third trimester, regardless of whether it's primary or non-primary, the data now shows that their chance of complications is extremely low.
The other question is if you're doing not screening, but I suppose screening if somebody's got symptoms.
Yes.
I mean, there's the obvious, rash, hepatosplenomegaly, big nose, but do you, when would you be thinking about doing it? Is it the sort of cold-like symptoms, or would you be thinking, look, you're pregnant, what symptoms would you be looking at for starting to think about doing a CMV?
Yeah, the symptoms are, a moderate fever, abnormal LFTs, I guess that's not a symptom, but hepatitis certainly is well described, and severe malaise. So anything that's kind of like a flu or rash isn't a big feature actually, but yeah, sometimes people can get a sore throat with it, but I think
not just the cold-like symptoms, but the more flu-like symptoms. Yeah.
Yes. And this is what would happen if we do detect someone with a primary infection in first trimester. We'd see them very quickly. Often we usually contact them by phone so that they're not waiting on tenterhooks to know what's going to happen, and just provide them a little bit of reassurance before we see them face to face. And if they meet the eligibility criteria of the randomized controlled trial, then we would offer them valacyclovir and perform an amniocentesis at around 20 weeks. It can be done a bit earlier to diagnose fetal infection. So we've got some patient information about valacyclovir, and we've only had, happily, only a few patients who've been in this situation, but at least we have something to offer them. In the past, we didn't have anything. So one of the interesting findings that has relevance to everyone out there is that of the people who were screened by their GP and were IgG negative, most of them, like a lot of them, 44% didn't know they were tested for CMV, but I understand that, they're tested for a lot of things. They might have forgotten, or it might have just been, not mentioned, but just bundled up in a general conversation about screening for infections. But 44% of them weren't aware that they were CMV IgG negative, and over half of them hadn't received any information at how to reduce their risk of CMV infection. So I think that's something really important. If anyone out there does happen to have a pregnant patient who is known to be CMV IgG negative, you really should give them some information about hygiene prevention practices. And as I said, this is really most important in first trimester, because the risk of fetal infection in second or third trimester is actually very low. So it's just a small window where people have to be vigilant. So we're not really ready for CMV screening, even though we now have an intervention. I think there's a lot of education that needs to be done for it to be implemented responsibly and safely, and we need to bring everyone with us if that's the way we are going to go. And there are lots of limitations in serology. IgM is particularly troublesome because we get a lot of false positive rates. So if someone's just screening at booking in someone with no symptoms, then an IgG would be sufficient. And then what we are going to do, and I hope you keep your eye out for it, when you see the email invitation come, we do want to survey GPs about their thoughts and about their readiness for routine screening for CMV, if that eventually becomes a recommendation in a year or so. So we will be asking you for your thoughts on this. So the take-home messages from CMV: it is more common than toxoplasmosis or listeria. We should be providing primary prevention advice on hygiene measures for all women at the first antenatal visit, or if they're coming for a preconception visit. And then we're not currently recommending routine serology, but if you do, in whatever way, detect a first trimester infection, please just refer us urgently and we will take it from there. So that's CMV. The next two topics will not take up as much time. So am I going all right for time there, Inez? Yeah, anyway, I will speed along. I know it's everyone's probably needing to get to dinner. So syphilis.
Oh, sorry, I realised I didn't turn off the video.
Yeah.
I just got about it. Was great because CMV is so important. You've got 15 minutes. Thanks, Lisa.
Yeah. Okay, good. All right then. So this is a story of a woman who came to the Mercy. She was unbooked with us and was transferred with preterm pre-labour rupture of membranes at 28 weeks from another hospital. And when she arrived, unfortunately, there was no fetal heart present, no fetal heart motion, and she quickly went into spontaneous labour and delivered a stillbirth infant. We had some booking bloods available from the GP, and the syphilis serology was negative at that time, and there was no other antenatal care. She had a lot of social issues going on, which meant that she hadn't attended after that initial diagnosis of pregnancy. She left hospital very quickly afterwards and was lost to follow-up, and on pathology of the placenta, there was acute velitis, and staining for spirochetes was performed and was found to be positive, and the PCR for syphilis was also positive. She hadn't consented to a post-mortem, so there was no post-mortem on the infant, but this is the placental pathology in the presentation is very consistent with congenital syphilis. So I think the important thing to take home about syphilis is that it's actually increasing in many countries around the world, and including Australia. So notifications in Australian women of reproductive age have tripled from about 5 per 100,000 to 16 per 100,000. And correspondingly, congenital syphilis notifications have also increased from 4 notifications in 2015 to 17 in 2020. So that's just really important signal to us that we can't be complacent. And of course, you'll all be well aware that if untreated, syphilis can pass on to a fetus. And if women are untreated, up to 50% will have a miscarriage, stillbirth, preterm labour, or a baby with severe physical and neurological disability. So I guess, the good question is, well, we're already testing everyone. Aren't we doing everything we can? Well, where it's evident from the public health data, universal screening doesn't always work because some women don't turn up for antenatal care, or they turn up and then they don't receive appropriate treatment. But more commonly, I guess in metropolitan settings, is that they test negative at booking, but they acquire syphilis during pregnancy. No one thinks to retest them. And so there are some health services that are actually doing routine syphilis testing in second and third trimester, and certainly Queensland is doing that in Western Australia. So the practice is variable in Victoria, but I believe Western Health is one of the health services that is routinely rescreening.
And we do that at the women's too, at 28 routinely.
Yeah, and look, I can certainly see there are a lot of advantages to that approach, because the other approach is to do risk factor-based screening in second or third trimester. These are the very well-known risk factors for syphilis. If you know your patient well, it's easier to have the conversation with them. I think in our antenatal clinic, these conversations don't happen as often as they need to, and part of the barrier is just not having really a rapport with a patient to have these sorts of conversations. But there are ways to have these conversations without offending patients or, contributing to any stigma. Given the time, I will be very quick to revise the stages of syphilis with you. The primary stage is in the 3 weeks after infection, which is characterised by the chancre or painless ulcer. One of the take-home messages is that a chancre can actually be painful if there's secondary infection. So if you're taking a swab for suspected herpes ulcer, test for syphilis at the same time, because it may be syphilis. And secondary syphilis occurs 2 to 5 months after infection, and may present with generalised symptoms such as malaise, low-grade fever, and a rash. And then latent syphilis. This is actually the most common stage that we see in pregnant women. These are women with a positive syphilis serology, but without any clinical symptoms or signs, and with no evidence of past treatment. So it's divided into early latent or late latent, but most of the time when we see patients, it's latent syphilis of unknown duration. We do try and ascertain from the history and from records whether it's early or late, because it affects the transmission risk to sexual partners, the duration of contact tracing, and the treatment duration. Happily, tertiary syphilis is very rare in Australia, but that has all the those classic manifestations. It can still result in mother-to-child transmission, but not sexual transmission at this stage. Now, what is the risk of transmission in untreated women? It's highest in those early stages where there's a lot more replication happening. So 70 to 100% vertical transmission for primary and secondary syphilis if untreated. And with late latent syphilis, it's about 10%. It's not transferred in breast milk, but it can transfer if a woman has an infectious lesion on her breast. And the fetal effects we see, if there are any, they can be miscarriage or stillbirth or preterm labour, as that case I just described. If the treponemes do enter the fetal blood circulation, they cause a really intense inflammatory response, and that results in the manifestations we see of hepatitis. So we see hepatosplenomegaly in the fetus. We also see anemia and hydrops and cardiomegaly. So you can see some ultrasound images there of a fetus with syphilis and a picture of a hydropic placenta, which is very enlarged, very thick and pale. The newborns, when they're born with syphilis, actually, most of them will be asymptomatic at birth. but may develop signs over the first few months of life, with other features such as the Hutchinson's teeth not really appearing till the child is 2 years of age or not. So what are we doing in pregnancy? We're doing the serological screening for syphilis with a treponemal test. And if that's non-reactive, then that's good. That's the majority of our patients. If it is positive, then it's confirmed with a TPPA or TPHA test. And if that's reactive, then it confirms that the patient has had syphilis sometime in the past, but it doesn't tell you whether it's what stage it is or whether it's been treated or not, because that stage is positive for life. We then use a non-treponemal test, such as the RPR, to then work out whether the patient is in an active stage or non-reactive stage, and that will help triage people into whether they needed treatment or not. So someone who's got a positive treponemal test and has an RPR that's positive, but has had a documented previous treatment with a decline and with no reinfection, they consider to have past treated syphilis. Those who've never had any documented treatment will be treated. And those that had treatment where the RPR declined and then started increasing again, they may have had reinfection and we would treat them again. So, and then there's the non-reactive RPR patients, and they're either people who've been treated and adequately in the past, or sometimes you get some tricky tests to interpret, and then we would seek advice of an infectious diseases specialist. What's the treatment? It hasn't changed. That's easy. It's benzathine penicillin, 2.4 million units once a week for 3 weeks. That's what we give for late syphilis of unknown duration. And you have to be really vigilant. It has to be 7 days apart. If someone has a dose interval of 8 or 9 days, then we would actually start all over again from the beginning and give them another three doses, exactly 7 weeks apart. And ideally, the treatment has to be completed at least 4 weeks before the baby is born for us to consider the fetus as receiving adequate treatment. The early stages of syphilis only need 1 dose, but that's a much more uncommon situation for us. There's no known resistance to penicillin, but it's the only acceptable one in pregnancy. We shouldn't be using ceftriaxone. So penicillin allergic women should have a desensitization protocol and then have treatment. So our hospital would organise that. And then if they're treated, we can reassure women that the chance of having an affected baby is extremely low, about 1 in 300 if treatment was given before 28 weeks, 2% if the treatment was given after 28 weeks, and up to 15% if there was no treatment. And that depends on the stage of syphilis, of course. We would still do newborn testing. The infant is going to have positive serology because of passive transfer from the mother, but we do want to test their IgM and RPR and compare it to a parallel sample from the mother. If the infant's RPR titer is higher than the mother's, then that does raise a concern of congenital infection. So babies at a low risk of congenital infection, that is babies born to mothers who've been treated in early pregnancy, who've had a normal newborn examination and low RPR at birth, they still get a follow-up examination and serology every 3 months until their RPR becomes negative. And we refer these women and babies for this follow-up at the Children's Hospital. If a baby is considered at high risk of congenital syphilis because the mother has not received adequate treatment, then they get a much more extensive workup and closer surveillance. So if you are looking after a woman, you've seen someone for a postnatal visit, she's been treated for syphilis in pregnancy, it would be good if you just checked with the woman that she knew that her baby needed follow-up and that something had been arranged. So hopefully you won't have to be chasing up the hospital to work out what the arrangements are for the baby, but that should have all been arranged before discharge. So the take-home message is congenital syphilis is back. So think of it, if you have a high-risk patient, consider re-screening at 28 weeks and 36 weeks. And if you see an ulcer, if you're thinking of herpes or anything, think of syphilis too. We're still giving the same treatment that we always did. And just a reminder that we still follow up the infants, even if they've been considered low risk and their mothers have been adequately treated. So that's where we're at with syphilis. I'll keep going. Parvovirus is very short.
Just quickly, somebody has put in a really good resource from ASHM about syphilis too. So if people
Oh, great. Good. Thank you. Yep. So parvovirus is very short, but also topical because of the epidemic in Europe. And this is one of the several patients we've had this year. She was transferred from a non-tertiary hospital with high drops at 27 weeks. She'd had some earlier investigations for an increased nuchal translucency and had a normal microarray, but they hadn't tested the fluid for parvovirus at that point. And the ultrasound features of anemia were present when we scanned her for for evaluation of the high drops. And indeed, this is the ultrasound images from that the day she was transferred. She's got cardiomegaly. So this picture on the left shows a very large fetal heart within the chest. It's occupying almost the entire chest. The middle picture is the skull, and there's marked scalp edema. So this grey layer here is all fetal skin that's abnormally thick. And then the third picture is a section through the fetal abdomen. There's the fetal liver there, and this black crescent around the liver is all ascites. We urgently organised an intrauterine fetal blood transfusion, and the sample there on the right that looks watery like cordial, that was the fetal blood sample, and that was the hemoglobin was 13, and then the sample on the left is after the transfusion. So a really dramatic presentation, and unfortunately for this baby, things didn't improve. Often 1 or 2 transfusions is enough, but actually this baby had quite severe cardiac involvement, had ongoing cardiomyopathy, and the pleural effusion, the pericardial effusion never improved. And unfortunately at birth there was also evidence of diffuse cerebral injury, probably due to that really severe anemia. And unfortunately, the baby had an intracranial hemorrhage at 1 week of life and passed away. So, again, unfortunately, a tragic story. They're not all like that. Most babies with parvovirus do survive, but it's just a reminder that it's certainly in our community. We mainly know it as slap cheek disease or erythema infectiosum. And as I mentioned, there's been an alert in Europe. It's highly contagious, and when there's outbreaks in schools and childcare centres, there's the secondary attack rate is about 50% in susceptible children and 25% in their teachers. So pregnant women who are also teachers really should be aware of this. And in our population, about 30 to 50% of pregnant women are susceptible to infection in pregnancy. Happily, unlike CMV or syphilis, you only catch parvovirus once. So once you're IgG positive, you can be reassured. Transmission, sorry.
At what gestation do you not worry if a woman might have been in contact with it?
Yeah, so I might just sort of skip along to that. Yeah, so that's the key thing. There is a window where people, where babies are most vulnerable to the infection. It's really in the 2nd trimester. So the parvovirus enters cells through something called the P antigen, which is highly expressed on erythroid cells, but also in the liver and the heart. And in this period of 9 to 24 weeks, the liver is the primary organ of hematopoiesis, and the fetus is really having to massively increase its red cell volume in this period. And also fetal red cells have a really short half-life. So if there's any suppression of hematopoiesis in this period, that's when they become severely anemic. So that's the period where we have to worry about maternal infection. So 9 to 20 weeks gestation. So it's diagnosed with serology. It's much more straightforward to interpret. You don't have to do avidity. It really is just the classic IgM appearing, and then IgG, and then immune for life. What do we do if someone has been infected in that high-risk period? We would monitor with ultrasound for fetal anemia. We actually monitor every week for 12 weeks because there have been late presentations like that patient I just presented, and we consider an intrauterine transfusion if they do show signs of fetal infection. So we measure the middle cerebral artery peak systolic velocity for that. And in general, the outcomes are very good if we treat before hydrops develops.
Right, I was going to ask that. So, you know, not teratogenic as long as one treats the anemia sufficiently.
Yeah. So abnormal neurodevelopment in survivors is up to 10% because of the hydrops and the hypoxic insult. But without hydrops, we would counsel women of a very good outcome. So just to take home message from Parvo, just think about it, just be aware it exists. The risk of the fetus is really with maternal infection before 20 weeks and good outcomes if we get there and are able to treat before hydrops develops. So thank you for your patience. I know it's late. 2 hours on Zoom is a lot, but these are
fantastic, Lisa. Look, great questions. I've asked a few along the way, but again, we've got some fantastic questions that we'll actually collate and email out to people. Lisa, do you mind just not stopping your sharing? Because I just wanted to share from this one. Just to
so you do want me to stop sharing?
Please.
Yep. Okay. So I will stop sharing.
Am I on now? Am I on now? I'm not sure.
Yes. Yep.
I'll do it from the current slide. Oh, sorry, guys. That was a fantastic talk, and I just wanted to quickly wrap up with the rest of them. Am I on slideshow? That's it. So those are the take-home messages that Lisa's got, which was the collation of the CMV, the syphilis, and also the parvovirus. Just a reminder that there is a infections in pregnancy course that you can do that Lisa has actually developed along, I think it was with Natalia Rhoda GP. And that's a fantastic resource, and you get some CPD points for that. Just some information on some infections, and we'll send this information out to people with the slideshow. Just a quick reminder about Health Pathways Melbourne, which many of you know about. It's a fantastic sort of desktop resource that covers a whole lot of issues. There's quite a lot on antenatal care and maternity care. And, you know, the Force of GP Liaison Services and Shared Maternity Care Services have had a lot in developing those as well. So there's some of the relevant pathways, and very usefully, there's actually an ability now to log your CPD points yourself via Health Pathways. So just a reminder about how to do that, and that will come out in the slides. Just some quick health service partner updates. Mercy Hospital have got their GP newsletter that they send out, and would like to encourage you to actually use their HealthLink referral forms. And they're also establishing a primary care liaison committee soon, and ELIs will come out about that. With regards to Western, they're starting some HealthLink soon, and that's starting in October of this year. So again, encourage you to actually start using health links with Western. Unfortunately, women's don't have anything like that yet. But that's their transition to HealthLink that will be happening shortly, and that information will come out via Western and also Northwestern Melbourne PHG. With the Royal Women's Hospital, we've got a webinar that's online, that's coming up shortly with public fertility care, along with the RACGP. Just a reminder, if you'd like to get our GP newsletter, where we give lots of sort of practical advice to GPs about what's happening in the world. And we also had 2 sessions recently on psychotropic prescribing or in perinatal mental health, and that's on our website as well. Just also some linkage to providers, to GPs that might actually want to become MTOP or medical termination of pregnancy providers, and some support that's available for you to upskill in that area. Session conclusion, you'll receive